Welcome to Life in Sirens, Behind and on the Scene, a podcast by first responders. We're your hosts, Sophie,
Jamie,
and Aubrey.
The content provided in this podcast is for informational and educational purposes only and should not be considered medical advice. The views and opinions expressed by the hosts and guests are their own and do not necessarily reflect the official policies or positions of any medical institutions, emergency medical services, or healthcare organizations. Patient privacy is a top priority, and all discussions involving real-world emergency situations are de-identified and altered to ensure confidentiality. Always consult with a qualified healthcare professional or your local EMS protocols before making any decisions regarding patient care or medical practices. Listener discretion is advised, as some topics may include discussions of real-world emergency situations.
welcome to our first episode of Life in Sirens podcast. That's Life in Sirens, not Lights and Sirens. Get it right. Or else. I'm just kidding. Welcome to our first episode. We are very excited to be here. I'm Sophie. You may know me as Paramedic Sophie on TikTok. I am very commonly found filming TikToks at work.
I'm Jamie. I have recently become Jambulance on TikTok. Check it out. I think I am probably the most likely to make everybody use a weird voice in a group setting.
Correct.
Yeah.
I'm Aubrey. Most of you will not know me as Hippie Paramedic, but I am that on TikTok. I am most likely to be friends with a psych patient in work and outside of work.
So today's episode, episode 1, we're going to be talking about where we're going and how did we get here. This is in regards to EMS. We talk about this often together, and that's that generally the public doesn't quite understand what we do in EMS. It's often that it's just a ride to the hospital, and we don't always understand the gravity of everything that we're capable of. Often, I think we've all been called this. We get called ambulance drivers. And we call it that, just like that, like psychopaths. Also, we are not the police. Tell me about everything.
We're not the police.
Be honest with me. I would love to know how to help you.
Tell me all the stuff. And, fun fact, I can't tell the police.
Can't tell them anything. Can't tell anybody anything unless you tell me I can tell them things.
Because HIPAA.
I think that first on the docket, let's talk about what kind of license levels are there in EMS and what do you have to do to become an EMS professional?
Yeah, how many times have you been in like a gas station or a grocery store and someone's like, yo, how you do that?
And how do you make so much money? Ha 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 ha.
So poor. So as far as EMS goes, it's different around the country in every single system. So some people run BLS systems, some people run ALS systems, some people run BLS with ALS intercept. And basically what that means is that you have an EMT basic, an EMT advanced, a paramedic, and a critical care paramedic. And so each system kind of utilizes those things differently. So in the state of Tennessee, you are far more likely to find an ambulance that has an advanced EMT and a paramedic on it. That is pretty much our standard. You will find some services that will run a basic EMT with a paramedic, and then you'll find some services that will run a basic and advanced, and that would be a BLS truck. So if you don't have a paramedic, you're BLS. If you do have a paramedic, you're ALS. And then some systems, like our system, we actually have quite a few double medic trucks. And then if you have a critical care medic on that truck, you then increase your scope of practice. And so there's certain things that you can do as a critical care medic that you can't do as a paramedic. And each state has their own critical care licensing exam. So we have our own specific exam that outlines what the state of Tennessee allows us to do on a truck.
And not only do we have our advanced EMT, some states you may hear this called EMT IV or EMT intermediate.
Oh yeah, because they still...
For those who are not listening from Tennessee, just kind of a miniature ALS gig. So how long did you have to go to school for, James?
Depends. It really depends. I got my EMT basic in Kentucky years ago, and I did a 1 month just down and dirty 9 to 5 days a week, and got my basic. And don't you worry, I failed the national registry because what even is that?
Yeah, I can't say that's quite adequate.
Yes.
But for me, I was able to attend a program that was integrated, and I did EMT basic and EMT advanced in one semester, which I think is totally appropriate. And I think that would be a great push to.
How did you do yours?
I did basic first, and I think that was about 6 months, and then I did a completely separate advanced class after that, which was I think 3 months.
Yeah, everybody that was in my advanced class had done an 8-month basic and then a 4-month advanced. Total, when you're looking at your EMS education, if you go through the traditional routes of basic, advanced, paramedic, it all collectively takes you about 2 years. So it's about the equivalent of an associate's degree. Your paramedic is a year, and it's 3 semesters actually. So it goes fall, spring, summer. Your summer semester mostly handles all of your clinicals, your preceptor rides, everything that makes sure that you're not going to get out on a truck and kill somebody. And then you can go further on and add certifications on top of that licensure, and that's what critical care is. So my critical care was 16 weeks, I believe. Is that?
That's about 18, I think.
18.
A semester.
Yeah, and so there's a couple different programs. But the critical care, it gives you a different perspective on the course of care that your patients go through. And so you look at some more like ICU-based knowledge and things that are a bit different that we don't quite talk about in emergency medicine as often.
And speaking of that, we talk a lot about work on the ambulance, but as an EMS provider, especially as you climb the chain, and not even necessarily as you climb the chain, even as an EMT basic, you have an opportunity to not only work on the truck, but a lot of places, for example, in hospitals, you could work as a patient care tech. A lot of hospitals have a position for paramedics. You can also branch out into other areas like flight medicine. So there's plenty of options. There's lots of room to play around and explore what suits you best. I think another thing that the general public doesn't quite always understand is that we're a very, very young profession. Generally speaking, if we were going to make a start date for EMS, modern EMS in the U.S., we pick 1973. That's kind of when the federal government kind of said, yes, you're legit. So we have a lot of room for growth. We have a lot of growing pains we're still working through. We are generally a short-staffed and under-recognized profession. I had no idea this was an option for me. I didn't even think about it. So we're working on that as well. So EMS is very versatile, and I think that it's a pretty easy career path. Once you get into it, it's, you don't have to go to a 4-year school. To be an EMT basic, you'd have a semester, essentially, of school. So it's a good jump out of high school, what do I want to be when I grow up, starting point.
Yep, you can get in the field and start earning a paycheck and,
Absolutely.
really get your feet under you.
It's a good medical entry job. We've had people in the past who have worked here as EMTs and gone on to be doctors and PAs and all sorts of things.
Hey, Sydney.
Yeah, hey, Sydney.
Oh,
we love
Sydney.
you. I miss you so much. So why the heck was EMS created, and kind of what do we do on the truck? Like, it's not just you call, we haul, necessarily.
Not anymore.
Right?
Not anymore.
Or at least it shouldn't be. So we looked at, looking back on EMS and the kind of how it started and why it started. There was a disparity in patients being injured or sick or dying at their home and being able to make it to a hospital. And so way, way back in the day, that's why doctors would make house calls, because there was no way to get you to the doctors. The doctor had to come to you. And then as we kind of progressed, we moved into funeral homes. Maybe we'd wish. Funeral homes and apparently some tow companies.
Yes,
and
we just researched that. Apparently tow trucks and tow companies would also be in the race to get paid to transport people to funeral homes and hospitals, which terrifying. Anyway,
which is wild. Just you on a flatbed.
That was the ultimate OG. You call, we haul.
Yeah, absolutely. And so we were doing that, and then they realized, like, okay, well, we're transporting people, but they're still dying, and so we don't really have much. And so then the ambulance hearses kind of started to evolve, and it was like, well, you have a tech now. You're not just back there alone anymore.
Here's some oxygen.
And then in 1973, they did some studies, and in 1966, really, they came out and they were like, all right, people are dying because we can't get them to the hospital. So 1973, it became federally funded. They were like, build your EMS services and we will give you dollars, says the government.
What I think is so wild is we have a friend, a very dear friend, whose parents have been in EMS for a very long time. And he was just telling us the other day about how when that federal mandate first started, there was like an overlap of where funeral homes would still transport people, but also there was a government entity that was doing the same thing. And they would legit race to calls. Like they would just sit there with a radio scanner in the funeral home, and the EMS service would race to calls, and whoever got there first got the patient.
Which is wild.
Safety
Wild.
first.
Yeah, which is just wild. And so we did all of those things, and now we have the system that we have now, which, mind you, is only about 50 years old. And so we look at patient care in the back of a truck, and does it make a difference? Do you think it makes a difference, Hobbs?
I definitely think it makes a difference. I have to, or else my whole life would be a lie.
Yeah, so we look a lot at if you're an old school medic, and not every old school medic, but a lot of old school medics, well, they have a you call, we haul mentality. And it's just like, we are time. All our importance is time from us to a physician. And they started to look at it and they said, well, what if we could put medicine in the field? What if we could actually do things for these people that would help them? And so now, as an evolving system, we're finding better and better ways to be able to actually perform medicine in the back of an ambulance.
And I think generally the level of care can kind of vary from state to state, service to service. But the level of care that we are capable, even just 50 years in, of being able to provide in the back of a moving vehicle is pretty impressive. So cardiac monitors, IV medications, we're moving towards, which at our service, we can RSI. For those who are not medically inclined or working in medicine, that is rapid sequence intubation. So we sedate you and we intubate you. So the care we can provide in the back of ambulances is wide in range, and obviously this varies from state to state, service to service, county to county, but things as simple as providing some oxygen via nasal cannula to as complex as performing a cricothyrotomy and RSIing a patient. So we can do a lot. There's a lot more that we need to do, and honestly there's a lot more simple things that could be added to our list of things
Absolutely.
that we could intervene on in the back of the truck, and that just comes down to research, education, and convincing the right people what's important, which can be a big struggle. But there has been a lot of acts over the years and federal movements towards promoting EMS research. But when you look at these acts and policies, a lot of them didn't become big until after 9/11. So if you really want to be a nerd, modern EMS doesn't really start till like 2010.
Which is wild.
Crazy.
It is crazy. And we've had cardiac monitors and things like that on ambulances since, in some states, since the 70s, since the 80s. But it wasn't required until the 2000s.
Which is wild.
We are young. It's hard to imagine a time when we didn't have that resource. I want to know what your heart is doing. So the things that we could add are pretty exponential at this point. And we are growing into all kinds of categories in EMS. One thing that we are doing as like a side project in EMS in this country is community paramedicine, which is pretty cool. So it's not just about that emergent care always. Sometimes it's about getting people to the right place and keeping people compliant so they don't end up in the back of an ambulance having an emergency.
And we're starting to realize that kind of like the old model of like the doctor's house visits is that if you can't get people to come to you, you can't really fix anything. And so community paramedicine is it's a forward step, but it's also kind of looking back at those older models and realizing that sometimes compliance and things like that matter in your populations that you serve repeatedly.
Absolutely.
And you were talking about things that we can do in the back of a truck and what those interventions are and how they've changed. So in EMS, when we talk about the things that we can do in the back of the truck and the resources that we have and the protocols, scope of practice, all of that, we can talk about a lot of really cool things that we do. But I think that something that is overlooked a lot when we talk to other providers about what EMS does is patient assessment. When we get to a patient, that is our patient. Rarely do we have more than one. I mean, it happens, but like ideally one person calls you, one person has a complaint, and that's our human. And so that is who we talk to. That's who we pay attention to. That's who we stare at and listen to. And there is a lot of indicators in people's environment and how you find them that can show you a lot about someone's condition that you can't see in an ER once we've already brought them to you.
Right. And even if we haven't declared this an actual emergency, which I know people get pretty frustrated that we're not always running emergencies, but thank God we aren't. I don't want people to be dying all the time.
That's also stressful.
But just because someone's not having an emergency, we can learn far more about their situation and why they, A, might not be compliant, B, why they could be continuing to get this infection over and over again, why they may be having some mental health crisis, things like that, based on where we find them.
Absolutely.
What their home looks like, what their family looks like, what their support system looks like. That's valuable information.
I think you're absolutely correct. And I think this really hit me when I was doing my clinicals for paramedic school in the ER. And I had a really hard time, like, feeling like I thoroughly assessed the patient because I would find them on a hospital bed in a hospital room, and I didn't have
in a gown. They're not even in their clothes.
Right. Like, I didn't have all that background information, and it didn't hit me until then how much information that gives you.
It really does. And then we just don't have a lot of invasive tools. So, like, you want to look at labs? Too bad. You want a chest x-ray? Can't. CT? Oh, no. Unless you're on one of the fancy stroke CT ambulances, which, like, if you
Rare.
are,
Fancy.
let us know. But
Yeah,
when
I
we,
want to talk to you about that.
Right?
I would just like to do a ride along.
yeah,
Yes.
please. Thank you. But when you look at the tools that we don't have, a lot of times I'm like, I just really wish that I could, like, figure out their labs. But I watch physicians and even nursing staff in ERs that have multiple patients, and they'll look at a patient and they're like, I want these 15 things. And they're all order sets, they're information gathering tools, except for talking to their patient. And when you look at how valuable that is, EMS as a standard, not necessarily just like us, but EMS will correctly call emergent diagnoses with close to no information. And especially in categorizing information as diagnostic information.
Yeah.
And that makes me
We have
proud.
close to nothing. We have a 12 lead, we have an end title. If you're real fancy, you may be able to get an ISTAT, but most of us don't carry that. And when you look at the things that we can deduce from the minimal information that we have, the information that your EMS providers bring you is very valuable.
Well, I think that absolutely highlights the importance of using these simple tools like cardiac monitoring, end-tidal monitoring. We have some very basic tools that can tell us so many things. We all
Vital
know
things.
that me, Sophie, obsessed with end-tidal. But it can show us so many things. And I think that's a big thing that we knock once we start trying to complicate things or we move towards like a hospital setting. It's not something that you've relied on to literally save someone's life, then you don't care about it.
Right. But for us, it is something that is very useful. It kind of brings us back in. I think bridging that gap between how hospitals, even not just even the public, but how hospitals perceive EMS
Absolutely.
and what we bring them. EMS brings you very valuable patient information. And if you just take a minute to listen to the things that we've learned, I guarantee you that it will improve your patient's care.
It might also blow your mind because we do see some wild things.
Oh, yeah. It may just be entertaining at best.
Speaking of people not really understanding what the heck is going on in the back of a truck, the public, especially in today's climate, and even in the last 5 years since we've all been at this service together, it has changed so drastically. It's a little alarming, and it makes me a little nervous about where we're going with things because we rely so much on public perception when it comes to what we're doing next, what our interventions are as far as like policy making, and that freaks me out.
And how to keep ourselves safe both physically and legally.
Absolutely. There's so much legal liability in this field, and oh my, if you only knew, you would cry every day like I do. Just kidding. Only sometimes when I watch the EMS reports. But it is so scary. It is. We obviously operate under standing orders, protocols. We have physicians sign off on these. But we have to determine that those are the appropriate interventions based on the protocols.
Absolutely. And have you ever found a situation in your life where there is a list, a step-by-step list that appropriately matches every situation you're
Never,
in?
not one time. Maybe
Right?
anaphylaxis.
Probably. But you have to use your brain, because although you have standing orders and protocols and that's what you operate under, sometimes a person has 6 things wrong with them.
Absolutely.
And there's
yeah.
not a protocol for all 6 things together.
No.
And so you have to figure out what's going to work for that person. And that becomes touchy in a legality situation, because which protocol did you follow? Well, I followed 4.
And you have to be capable of critical thinking enough in that emergent situation sometimes to be able to pick up the phone, still manage your patient, and say, I don't have orders for this, but I know this is the appropriate thing to do. This is what I need you to allow me to do. Are you good with that? So, like, you also have to decide things without any physician
Absolutely.
saying that it's appropriate or not.
And to take the time to be able to call medical control. Every system does it differently, but the way that our system does it is that the hospital that we most predominantly transport to, that one of our medical directors is affiliated with, we call them and we talk to one of the attendings in the ER. They also have a residency program, but our protocol is to talk to an attending. And so we will call them and be like, this is what I have. I don't have protocols for this. This is what I would like to do. Are you good? And then they will say yes or no. The problem with that is that you have to have time to do that.
Yeah.
And sometimes you don't have hands, nor do you have time. And so you may know what the appropriate intervention is for this person, and you may be comfortable performing that intervention. But if you do not have protocols for that, and you do not have the hands, personnel, or time to stop and call somebody,
You better get creative.
you better get creative within your protocol. And so that's a tough bridge to gap sometimes, especially with as type A as we all are.
Absolutely. And the question can still be asked, well, why didn't you call for help?
Mm-hmm.
Why didn't you call for medical control? Because the patient was beating me
I
up.
only have 2
They
paws.
stole my radio and threw it out of the truck.
That
and we
did
started
happen,
trouble.
actually, once.
That did happen once.
Oopsie. So, as far as public perception goes, I think people don't understand that we are operating typically like based on what a doctor has written out for us.
Yes. It's not like willy-nilly. We're just out
right.
there slinging things around.
And obviously, I think that we, Jamie, Aubrey, and myself, are quite biased because we are very lucky to work in a system and a service that is wildly professional comparatively. We have some hotshot looking uniforms. We have some hotshot medics. We are lucky. But public perception can go down the drain very quickly with something as simple as an untucked shirt.
Absolutely.
Oh, yeah.
That sloppy t-shirt with the really big neck. I
Stretched
dislike
out.
it.
Big necks always
Man,
get ya.
I hate it.
Sweat stains.
It's clearly mine is like so close to my neck right now, but like the stretched out shirts, the wrinkled, untucked, unzipped boots with their pants like half bloused kind of.
I think that's my ick. The unzipped boots.
That is my
Yeah.
biggest EMS.
My pants
ick.
get stuck in the top of my boots a lot when I get out of the truck, and Aubrey and I were partners, and she repeatedly will be like, do not take one step towards this call until you fix your pants.
Fix your pants.
But that look, that sloppy, just like laissez-faire, couldn't care less look, that matters.
Public perception is reality, and if you
Yes.
look like you are not a professional, we will not be
Treated like
treated
one.
like professionals. And that's where we have to start, is having standards, holding people accountable. And I think that even comes down to a state level. As EMS services, all of our ambulances get inspected several times a year, and that's something that we have to be held extremely accountable for. And it's very important, obviously, because the things that we have in our ambulances and how our ambulances operate, our lives and our patients' lives depend on those things. But the future of EMS also depends on public perception, especially in today's climate. And when we're running around in uniforms that are ridiculous, this is me promoting the ban of t-shirts in EMS. Come at me, that's fine. When we look ridiculous, no one takes us seriously. So I think also a really great idea would be to also, when we're doing those truck inspections, if a crew is looking wild, you get fined.
Oh, the state. What up?
Your boots are unzipped and your shirt's untucked and you're
Yeah.
smoking a cigarette on hospital property, guess what? Fined. Okay?
Yeah, your truck and your equipment has to be presentable, and you as a provider should also have to be presentable.
Absolutely.
And that does not mean it's not egregious, but it is just dress yourself in the morning.
I don't mean that
Take
half
a
your
shower.
shirt is accidentally untucked because it's
No.
3 a.m. I mean that it is lunchtime and you look a fool.
Take a shower, tuck in your shirt, iron your uniform if it can wrinkle. Like, there are just things that as providers we should do, because if you look at any other profession that you have to trust with like high stakes, if you look at police, if you look at lawyers, Well, look at physicians. If you walk into their office or if they walk into your home or whatever it is, if they look like they can barely care for themselves, you do not trust them to do whatever it is that you're wanting them to do.
No, look like you mean business.
Yes. You do not trust a lawyer in court who may be extremely, extremely intelligent. But if they look disheveled and unkempt, then you're not going to trust them to defend your case. And if we come in and your mother is dying on the floor and I look like I still have lunch on my shirt and I look like I can barely get myself
Bring
to
an
this
extra
call.
Uniform.
Yes. If I look like I can barely get myself to this call, then, and I'm your last chance to like help your loved one, you are not going to be confident in my ability to do so. And I may pleasantly surprise you, but that's not the point. So you need to be professional and look professional because we can't be treated as a serious entity if we don't look like one.
Absolutely. And I think going towards like when things go wrong on scene, it's very easy afterwards to be like, well, they couldn't even get their own crap together. They look terrible. How did I expect them to? You know, the liability increases when you cannot look like you are competent.
You know how we always say that you can't be dumb and mean?
Yes.
Yep.
Like, you can't be incompetent and look incompetent.
Right.
I think, that's a great addition.
If you look very, very competent, but you maybe are not the best provider, you're going to get a lot more slack by your patients. And I'm not saying that that's like
appropriate. But it will help us people who are trying our best in the profession. We are seeing a lot of EMS in the media right now. And I'm not saying that they showed up with their shirts untucked and their boots unzipped, but that is just another reason to add to the list, to the pile of things that why we shouldn't be doing what we're doing.
Yeah. Our service recently ended up in a TikTok that was like pretty identifiable that it was people that worked in our county, and they look great. Uniforms look great. The fire department that rolls with us look great. The police department that rolls with us look great. Like everybody looked so good. And even like whatever was going on in that video, it was not inappropriate. Everyone was behaving appropriately. But they all just looked very put together. And I even, knowing some of those people, was like, yeah, they got it. So speaking of other agencies and public perception, who do people think we are?
The fire department.
The fire department.
Or the police.
So,
and occasionally the police.
Right. So, in our system, how does it work? Who's who?
We are a county EMS service, and then we have multiple cities within that, which each have their own fire department. And pretty much every city within our county, every fire department runs medical calls with us. So basically on every medical call, you will get the fire department, you will get EMS, and then when needed, police.
Yes. So we have multiple fire agencies, but we are the only EMS agency and we run the entire county.
Correct.
Now that's not how every place works. If you go, a little bit north of us, there's a large city and they are fire EMS. They're a fire-based EMS system. And that's how a lot of parts of the country are. We are biased, but we have a preference to have individual EMS systems separate from the fire system.
Which is pretty common in the Southeast.
Yeah.
Which is where we're located.
And the reason that, we kind of, and I enjoy it that way, is because EMS is able to be both a first responder, but also a part of the medical world. It's nice to be separate from them. We all get to work together and we get to learn together. So I think there's something to say for a separate EMS system.
Yeah, and I run across this problem often when I make videos and speak to people on social media or even like in the conference realm, is that everyone is going to be biased. And we only can be familiar with the experiences we've had, and even something as simple as, we are a high volume service. Oh, you only ran that many calls? Okay, that is so. How close are you to the hospital? How big is your zone? How long is your shift? Okay,
way too many variables.
There's too many variables, and even with the combination fire EMS, there's too many variables to compare it to us as just an EMS only service. And generally speaking, there's going to be a few different types of EMS services. There's going to be private service. There's going to be hospital-based. There's going to be municipal or county services. And then sometimes there's federal. For our region, Southeast, very commonly county-based. Our state, widely county-based. Yeah. But you go out west, very commonly private. Mm-hmm. You go to the East Coast, very commonly municipal. Mm-hmm. So it's not comparable. I can't say that there's one that's better than the other.
Mm-mm.
I can't say that the public perception changes except for when it's fire-based, because everyone loves fire.
People love firemen.
They got that marketing down. It's impressive.
EMS is terrible at PR. And part of it is the nature of our job. It is really hard with the HIPAA compliance that we have to fall under. But it's hard for us to be like, hey, we ran this really cool high stakes call where our crew did this very impressive procedure, and bam, we saved somebody. And it's hard to promote that because you have to take out identifying information. You have to make sure the family can't identify the patient. You have to make sure the patient can't identify the patient.
And then if you do want that to happen, you have to jump through so many hoops. You have to get paperwork signed. You have to somehow find the family, track them down, contact them, be like, would you be willing to do this? Like, it is a lot.
I am 0% mad at them for being fantastic at PR. I just want us to also be good at PR.
Oh, yeah.
It would feel nice sometimes to be acknowledged, but I think that is a big reason why we don't get the public acknowledgement or recognition, is because we are the field, which we're new, but still, we are the people who come in and we say, this is our job. We keep our head down, and then that's it. Which is changing, I think.
I think we're very much like, we signed up for this.
Yes.
And so
this is just, we're doing our job.
Yeah. And to be clear, the discussion of public acknowledgement and praise and things like that is not about being praised.
Right. It's not
about people being like, thank you. It's about funding.
It's about funding and taxes, and are the people you serve willing to pay the extra taxes because it's going to go to the EMS service, or are they going to be like, no, because what do they do?
Right. And if you ever look in the system that you work in, look at your funding, see where it goes. Public perception matters so much for being funded. And I think that if people know what you do and who you are.
Well, absolutely. And then when we're not funded, it's hard to retain employees. And unfortunately, people are going to those departments that are fire-based because they do have the funding and they can pay adequate wages.
I think it's really interesting that something as trivial as social media presence or perception, all of those things have such a trickle-down effect on us.
Perception.
It's almost like you have a talk about this. It's crazy.
It's almost like I do. Perception is reality, too.
If you're a director of an EMS service, you should think about that. It's very interesting.
And to some degree, like, you just want someone to acknowledge that you
did a hard thing,
are doing hard things.
Yeah.
And so I think that can leave us kind of down in the dumps a bit. And it's tough to rectify that with public perception and your own morale within your system.
Yeah. Because it's a lot harder to, when you think about public perception, to recover negative perception than to be like, oh, we post all these wonderful things that we're doing all the time every week, and then this one bad thing happens. Because you can look at national coverage on EMS. Yikes. Painful. As informed as we need to stay about our careers, I try not to watch because it's painful.
I think to your point, if we were more active in the positives of all of the things that we do, then when you see one bad thing, but right now, the only time that people see EMS
is bad. Jail, prison, murder
is when it's bad. Night Watch did like a very cool thing for EMS, like being kind of
absolutely.
Holly, if you listen to this podcast,
big fan. You're wonderful.
Will you marry me?
Yeah, that. But that did a huge thing of people seeing like, what is the inside of an ambulance like? Like, you know, on all the medical and ambulance shows where like Chicago Fire does this, where you roll in, they like get there, they get the patient. Sylvia just loads them up so good. They hook the stretcher on the back of the ambulance, and then bam, they stay right there, hooked to the back of their ambulance, but not in it. And they then provide all the patient care right there. And like, if you just watch that as a civilian, you're like, oh, reasonable, because everybody can get to them. But as a provider, I'm like, oh, it's because they didn't want to figure out how to film inside a truck. That's why they did that. But like, we would be just reprimanded aggressively if we ever just like attached the stretcher to the back of the truck and then just coded somebody out there.
What was some of the other... This was a really big thing during post-lockdown COVID. A lot of these shows came out really big. Oh, Live Rescue. I think that did do a lot of good things for us.
Yeah.
And again, putting ourselves out there, showing the world what we can do is so important. and we don't do it enough. Absolutely, this is our job, and I don't think necessarily we should go around, rewarding everyone for showing up to work, but I do think that we do need to recognize that this is a very undervalued profession. It's a very exhausting profession, and generally providers do it because they love it, but it doesn't mean we don't love it and it also hurts us.
Yes, like nobody gets into EMS for the money, but that also doesn't mean that you shouldn't earn a living wage. You could also be better funded and better paid and, help the public understand what in the world do these people do? Where do they come from? Where are they housed? Who pays them?
There are a lot of questions here, and
right?
That's the whole thing, is public perception is everything, and we have to change that. I think wrapping things back to where we started was absolutely nowhere. We were picking people up in hearses and taking them to sometimes just the funeral home.
A little too on brand for me.
Yes. So we have come a long way. Do we have so much troubleshooting to do? Absolutely. And that is a big reason why we're doing this podcast too, is we have a lot of significant topics we would love to discuss. We would love to hear many of our listeners' opinions on these topics. And I think the only way we get through the EMS crisis is gathering the forces of people who are absolutely passionate about this, and we're not going to get paid for it for a while. We're just not. And
you're going to have to put in the work even though it's not your job.
Stop saying that. It's not my job. It's our responsibility.
It's not your fault.
It's not your fault.
But it's your responsibility.
We have to do better. So next week, we'll also be talking about leadership, which we know this is all of us know. We have had some terrible leaders. We've also had some fantastic leaders, which we'll be talking about both of those sides of things.
And some things to kind of look forward to past that are going to be education in EMS, where it's been, where it's going.
Yes.
And how we kind of shift. Let us know if you want to hear more like specific educational topics like capnography and 12
100%.
leads and things like that.
And that's kind of why we chose where we are and where we're going as our first episode, because we have a lot of growth and we have a lot of ground to cover, and that's what we're going to do in this podcast. Be sure to follow us on our platforms, currently YouTube, Spotify, Apple, TikTok, and Instagram, and if you're inclined, the old Facebook.
Hey.
We'll see you guys next time.
This has been Life in Sirens, produced by 3 nerds trying to bring you content that you might actually care about.